Assalamu alaikum. I am Dr. Atif Raza and this is Pete's Mentor. This is the second part of approach to neonatal cyanosis, that is the blue baby. In this video, we will discuss the two main cause of cyanosis, that is RDS and PPHN. So let's start. Sometimes the blue baby isn't blue because the lungs are full of disease. Sometimes the lungs look completely fine and the baby is still dying. This is because in neonatology, there are two respiratory enemies that steal oxygen in totally opposite ways. That is, one in which the lungs remain collapsed, and the second one in which there is resistance. One baby turns blue because the lungs collapse like a deflated balloon. This is RDS, that is respiratory distress syndrome. And another baby turns blue because the lung refuses to open at all, not from fluid, not from surfactant, but from pure pressure. That is, there is shunting. So, here is the shunting of blood which results in a condition which is PPHN. In RDS, the X-ray shows white out lungs. But in PPHN, the lungs looks normal because this is due to shunting of blood. And here's the truth. If you treat PPHN like RDS, you lose the baby. And if you treat RDS like PPHN, you destroy the lung. So these two are having different games. So you have to treat it differently. So you have to know how to diagnose these two conditions. So today, in this video, we are going to master the two most dangerous respiratory causes of neonatal cyanosis and the exact bedside game plan that saves lives. So let's start. So we are starting this topic with the first one, that is in which the lungs remain collapsed, that is respiratory distress syndrome. I've already discussed RDS in the previous lecture, which you can find in our playlist. In respiratory distress syndrome, the baby is usually premature, which came in emergency department with grunting, retracting, and having a ground glass appearance on X-ray. So these are usually preterm babies came to ER with grunting, retracting, and ground glass appearance on chest X-ray. This is because of deficiency of surfactant. So here in RDS, preterm babies which are premature having deficiency of surfactant. So surfactant are not present in adequate amount, resulting in collapsed lungs and ground glass appearance on X-ray. This is just a simple physics as per the law of Laplace. Laplace law of pressure, which states pressure equals to 2 times of tension divided by radius. So without surfactant, surface tension is high. So if the surface tension remains high, it results in collapse of small alveoli. So here in this scenario, that is an RDS, small alveoli remain collapsed. That creates atelectasis, that is the VQ mismatch and hypoxemia. So here is VQ mismatch, which results in hypoxemia. So in respiratory distress syndrome, we do not jump straight to intubation anymore. We have a ladder of management. This is a 3-step ladder. In step 1, if a baby is breathing, we start CPAP. So at step 1, we start CPAP at a pressure of 6 to 8 millimeter of mercury. Why? Because CPAP stents alveoli open and prevents collapse. And early CPAP reduces the need for mechanical ventilation. So here in step 1, we start with CPAP with a pressure of 6 to 8 millimeter of mercury. In step 2, we do not give surfactant prophylactically anymore. We give it when the baby declares themselves. That is, we have started CPAP at the pressure of 6 to 8 millimeter of mercury, but baby requires FiO₂ greater than 30%. So step number 2, when the FiO₂ is greater than 30% and baby is on CPAP, we usually give surfactant at this moment. So step 1 is CPAP. When the baby is breathing spontaneously, we start with CPAP at the pressure of 6 to 8 millimeter of mercury. But while baby is on CPAP and it requires FiO₂ of greater than 30%, we usually give surfactant at this moment. Previously, we give surfactant to every preterm baby which are suffering from RDS, but now there is a change in approach. If the baby requires FiO₂ greater than 30%, we give surfactant. And the preferred method to give surfactant is less invasive surfactant administration or INSURE, that is intubate, surfactant and re-extubate. The third one, if the baby is in severe apnea or having persistent respiratory acidosis, that is pH is less than 7.20, we usually intubate at this moment. So step 1 is CPAP, step 2 is surfactant, and step 3 is intubation. Intubation is required for any child which are suffering from severe apnea and having persistent respiratory acidosis, having pH of less than 7.20. So intubation is the last step. Here we need a tidal volume approx 4 to 6 ml per kg. So tidal volume is 4 to 6 ml per kg. This is to avoid volume related or volitrauma. This is all about respiratory distress syndrome. Now come to the scary one, that is persistent pulmonary hypertension, that is PPHN. So the second one is PPHN, persistent pulmonary hypertension. PPHN is the window maker. Normally at birth, pulmonary vascular resistance drops. Blood, blood rushes into the lungs, but in PPHN, that resistance stays high. So in PPHN, pressure remains high. Due to this pressure, the pulmonary arteries remain clamped shut. So, due to this pressure, pulmonary artery remain collapsed or clamped shut. And the blood shunts right to left through foramen veil and the ductus arteriosus. So, in PPHN, this pressure remains high and due to this pulmonary artery remains shut, so blood shunted from right to left through foramen ovale or ductus arteriosus, so it bypassing the lungs. So when the blood bypasses the lung, oxygenation doesn't take place, and due to this the baby remains blue. That is, the baby or the neonate remains cyanosed. So here the problem isn't inside the lung. Problem is due to this pressure which remains high. So here the management is aggressive. We have three goals. The most important is oxygen. The second one is pressures, and the third one is vasodilators. Remember, oxygen is a drug. In PPHN, oxygen is a pulmonary vasodilator. So here we give oxygen as a pulmonary vasodilator, and we have a target. The preductal target of saturation is usually greater than 95%. So remember, we usually set a preductal sats greater than 95%. This is because we flood the vessels with oxygen so they relax and this pressure overcomes. Second one is pressures. To stop the shunt, systemic BP must be higher than pulmonary pressure. So we have to keep systemic BP greater than pulmonary blood pressure. If the baby is hypertensive, the shunt worsens. So for this, we usually give dopamine or epinephrine to keep the baby normotensive, and here we give fluid boluses but with caution. According to Nelson suggests systolic BP greater than 50 to 60 mm of mercury in term infants. So we keep or we try to keep systolic BP greater than 50 to 60 mm of mercury. The third one is pulmonary vasodilator, that is inhaled nitric oxide. If oxygen and the blood pressure aren't enough, use the magic bullet, that is inhaled nitric oxide. The usual dose for this is 20 parts per million. Mechanism of inhaled nitric oxide is basically it acts as a selective pulmonary vasodilator without dropping systemic blood pressure. So when we give inhaled nitric oxide, it starts improving saturation within the 30 minutes. But after giving inhaled nitric oxide, if the saturation is not improving within the 30 minutes, re-evaluate your diagnosis either with echo or other labs investigations to rule out structural defects. So for the management of persistent pulmonary hypertension, we have three management steps. First one is oxygen. We give oxygen here as a pulmonary vasodilator, and we try to keep preductal saturation greater than 95%. Second one is pressure. We usually keep systemic blood pressure greater than pulmonary blood pressure, and if the baby is hypertensive, which may result in worsening of the shunt, so to keep baby normotensive, we start dopamine or epinephrine. Here we give fluid but with cautions. As per the Nelson, systemic blood pressure should be greater than 50 to 60 millimeter of mercury in term infants. The third one is pulmonary vasodilator, that is the inhaled nitric oxide. If the oxygen and pressure are not enough to reverse this, we start inhaled nitric oxide, which is a pulmonary vasodilator. It acts by selectively dilating pulmonary vessels without dropping the systemic blood pressure, and we give it usually at a dose of 20 parts per million. After the inhaled nitric oxide, saturation start improving within the 30 minutes. If it is not, you should re-evaluate your diagnosis and do echo to rule out structural defects. So this is all about the second part. So to sum up this lecture, what we have dealt over here, that is RDS and PPHN. The key takeaways are RDS, it is usually in preterms, having ground glass appearance on X-ray. Here the lungs is collapsed due to high surface tension because of surfactant deficiency. We start with CPAP at a pressure of 6 to 8 millimeter of mercury, but at CPAP, if neonate require FiO₂ greater than 30%, we give surfactant by either LISA or INSURE method. In severe apnea, we usually intubate the neonate. Or if it's PPHN, these babies are usually term babies having high pulmonary pressure. So there is shunting of blood. We give oxygen to keep saturation greater than 95%. Here oxygen acts as pulmonary vasodilator. We boost the blood pressure, systemic blood pressure, by giving dopamine or epinephrine. And still if these two didn't work, we give inhaled nitric oxide. So here we calm the lung and support the heart. Remember, in PPHN, handling stresses the baby and increases resistance. So you should have a protocol in PPHN, that is the minimal handling. So order minimal handling in every neonate which is suffered from persistent pulmonary hypertension. So sedate them, keep them quiet, let the medications work. This is all about the second part of neonatal cyanosis, that is the blue baby. In part 3, we complete the trilogy by tackling the cyanotic congenital heart defects, the anatomical nightmares that drugs alone can't fix. Hope so. All of you have having a crystal clear picture how to manage respiratory distress syndrome and the persistent pulmonary hypertension. But still, if you have any query related to these two topics, you can ask me in the comment box. I will definitely answer your queries. But one point you all should remember, these lectures are just for teaching purpose or educational purpose. These are not intended for any medical advice. For any medical advice, consult your doctors. If you have any query, ask me in the comment box. Till next video, Allah Hafiz.